Good evening, everyone. So, today's topic
Sure.
is organ donation and transplant. And the faculty that we have here is Dr. Nikhilesh Jain, sir. He is a director and operational head, Department of Critical Care Services at CHL Hospital, Indore. Sir, you may take over. Thank you.
Okay. So we've done a basic session before, and today I would be doing the true false question stem, going slightly fast through this so as to complete the sessions. And do tell me if you don't get my voice or if I'm not audible, because what I've noticed is in between on two occasions, no, suddenly the Zoom came to a standstill. So that is what. So this is first question. CMV management in solid organ transplant recipients in ICU. The options are A. You have to answer all of them in TT in true and false things. A. Donor positive, recipient negative status carries the highest risk for CMV disease. B. Valgan cyclophyr prophylaxis is usually recommended for at least 6 months in high-risk kidney transplant recipients. C. CMV disease typically presents only after the first post-transplant year. And D is CMV viral load, which does not correlate with the disease severity. So you can give the answers in the chat box. No answers? You are supposed to take up all the options, Fahmuddin? Okay, fine. Utpal has written TTFF, TFTT, Arunima. Anybody else? F. Fahmuddin has written. So, fine. I will go on to the answers. So these are the answers, Donor positive, recipient negative. That is D plus and R minus status carries the highest risk of CMV disease. That is correct. And Valgan cyclophyr prophylaxis is usually recommended for at least 6 months in high-risk kidney transplant recipients. That is also correct. Now, CMV disease typically presents only after the first post-transplant year. This is indeed false or wrong because it can present even as early as first, second week as well. And CMV viral load does not correlate with disease severity. Again, this is false because it does correlate with the disease severity. The higher the viral load, the more invasive and the more severe would be the disease. Go on to the next question. Okay. Antifungal prophylaxis in lung transplantation, this is about that. So lung transplant recipients have the highest invasive fungal infection risk among solid organ transplants. Voriconazole is commonly used for early antifungal prophylaxis post-lung transplant. Then C is nebulized amphotericin has no role in lung transplant recipients. And D is universal lifelong antifungal prophylaxis is standard of care worldwide. So let's see what your answers are. Okay, ऊपर है second TTTF. Point within the TTFF. So now two TTFFs. TTTF. So we've got a whole lot of variation in the answers. We'll go through this now. So the correct options are TTFF. Lung transplant recipients have the highest invasive fungal infection risk among the solid organ transplants, which is true. Voriconazole is commonly used for early antifungal prophylaxis post-lung transplant. This is also true, even though it is known to interact with certain drugs which are going to be used, commonly called as calcineurin inhibitors. We'll come to those questions. And C is nebulized amphotericin has no role in lung transplant recipients. This is false. It does have a role. Then D is universal lifelong antifungal prophylaxis is standard of care worldwide. It is not. So the option is again false here. Third question. Primary graft dysfunction after lung transplantation. So again, primary graft dysfunction usually develops within the first 72 hours after transplantation. Second is pathophysiology, which resembles ischemia, reperfusion-related ARDS. Then the third option is PGD severity has no association with early mortality. And the last one is ECMO has no role in severe primary graft dysfunction. This is all pertaining to lung transplant. Can I have the answers? Okay. Pal, Aruna. Anybody else? Okay. So we go on to this. The correct answers are TTFF. That is, primary graft dysfunction does develop within the first 72 hours post-transplantation. The pathophysiology does resemble ischemia reperfusion related ARDS, and PGD severity has no association with early mortality. It has an association. So the option becomes false here. And ECMO has a role in severe primary graft dysfunction in the means that it can be used as a standby means to support the lungs at that point in time. Fourth question, antibody-mediated rejection in kidney transplant ICU patients. Now, donor-specific antibodies, first option is donor-specific antibodies are central to the diagnosis of AMR or antibody-mediated rejection. Plasmapheresis with IVIG is commonly used in severe antibody-mediated rejection. Now, there is a universally standardized evidence-proven treatment protocol for antibody-mediated rejection, and antibody-mediated rejection cannot occur in early post-transplant period. So, can you give the answers? Mustafa, Faibuddin, fluency is improved. And Arunima. So again, three different type of options, PFTT, FTTF, and FTFT. Okay. Let's see. Wait a minute. Huh? So correct answer is TTFF. Donor-specific antibodies are indeed central to diagnosing the antibody-mediated rejection. And plasmapheresis with IVIG is used as a rescue for severe antibody-mediated rejection. There is a universally standardized evidence-proven treatment protocol. No, there isn't one as of now. And antibody-mediated rejection can occur in early post-transplant period. You may pick it up very early as well. So the option is again false there. Go on to next question. Immunosuppression adjustment during septic shock, The first option is abrupt cessation of all immunosuppressants is recommended in septic shock. B is antimetabolites such as mycophenolate are often reduced or held during severe infections. C is calcineurin inhibitors may worsen nephrotoxicity during sepsis. And D is risk of rejection must be balanced against infection severity. You have the answers. So Fahimuddin has put all as D. Utpal has given us F, T, 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 T. Anybody else? F, T, T, T. Mushtaba has also confirmed the same. So FTT seems to be the majority. Let's see. This is correct. FTT is correct. So abrupt cessation of all immunosuppressants is recommended in septic shock. No, it is false. You cannot stop everything abruptly. Mycophenolate and antimetabolites are often reduced or held during severe infections. This is correct. Calcineurin inhibitors may worsen nephrotoxicity during sepsis. That is also correct. And the D statement is absolutely, in a sense, a sort of an easier option to explore in the sense that risk of rejection has to be balanced against severity of infection at all times. So going on to the next question. BK virus infection in renal transplant recipients. BK virus reactivation, first option is BK virus reactivation, commonly presents with a rising serum creatinine, and second is reduction of immunosuppression is the first line therapy. Third is cidofovir, which is uniformly effective and safe. And D is BK virus infection has no impact on graft survival. So can we have the answers here? Okay, BFFF. Mustafa has given DFDF. Fahimuddin. Anybody else? So we'll see the answers here. The answers are TTFF. So BK virus reactivation does present with a rising serum creatinine in a renal transplant recipient. And reduction of immunosuppression is always a first-line therapy as far as treating a BK virus infection is concerned. Cidofovir is not uniformly effective and safe, and BK virus infection has an impact on graft survival. So that is it. Okay. So CAR T therapy related cytokine release syndrome. So first option is cytokine release syndrome severity does not correlate with tumor burden. That is first. Second is tocilizumab. Tocilizumab is the first line therapy for moderate to severe CRS. Third is tocilizumab effectively treats isolated neurotoxicity. And fourth option is corticosteroids are used in cytokine release syndrome. FFFT. So I said FTFT and TTFT. Let's see again. Plethora of different answers. This is FT. That is CRS severity does correlate with tumor burden. That is first. Tocilizumab, correctly spoken, is the first line therapy for moderate to severe cytokine release syndrome. It does not effectively treat isolated neurotoxicity, and corticosteroids are indeed used in cytokine release syndromes. Okay. So GCSF use after hematopoietic stem cell or CAR T therapy. Uh, One of the options is actually been given. I'm so sorry for that. So, but we can still answer the first three options. I forgot to, sort of blink it. So GCSF may theoretically worsen CRS if used early after CAR T therapy. Evidence on optimal timing of GCSF post CAR-T remains mixed. And third is GCSF is indicated after HSCT. D, you can remember. I'm so sorry. I could not remove the option out of that. It's my mistake. So now you have to answer mainly the first three options. D option is indeed false. Okay. So Faimuddin has written FTTF. That is what I think so. TTT. TFT. Okay. So it becomes difficult. Everybody comes out with a sort of a different answer. It is good that way. So the answers are basically TTTF. All the other options are correct. So GCSF can actually worsen your, cytokine release syndrome if it is used early after CAR T therapy. The evidence on optimal typing is remains mixed. Some people would like to give it early. Some people would like to wait for some time. Some people may really hold it and give it later. But most of the times it is in the first two categories. GCSF is indeed indicated after a hematopoietic stem cell transplantation. And of course, it has a role in ICU management of neutropenic sepsis. It has a role. So that is statement is false. Okay, this is regarding venous thromboembolism in hematologic transplant patients. So hematopoietic stem, your HCT recipients, they are not at risk of both thrombosis and bleeding. First option. Second is pharmacological VT prophylaxis may be used selectively with careful monitoring. C is mechanical prophylaxis alone is always sufficient. And of course, D option is venous thromboembolism risk is negligible in neutropenic patients. So let's have the answers. FTFF, Anonyma again, FTFF and FTFF. Okay, so this time there's a huge consensus. Let's see, this is maybe an easier question. All of you got it right in a way. Of course, hematopoietic cell therapy recipients are not at risk of both thrombosis and bleeding. They are at a risk acquiring both. Pharmacological prophylaxis may be used selectively with careful monitoring. This is also correct. Mechanical prophylaxis alone is always sufficient. Now, this is one subset wherein mechanical prophylaxis alone may not be always sufficient, and you may need to use a pharmacologic means as well together. VT risk is not negligible in neutropenic patients, especially when you're talking about hematologic transplant patients. Right. So next is ECMO in transplant critical care. So ECMO can be used as a bridge to lung transplantation. Second is ECMO is an absolute contraindication after solid organ transplant. Third is ECMO may support recovery in severe primary graft dysfunction. And D is post-transplant ECMO always indicates futility. So you can attempt this. Part of this has been covered in the previous questions. So you may find an overlap here. TFTT, TFFF, TFTF. Okay. So this is TFTF, the answer sequence. ECMO indeed can be used as a bridge to lung transplantation. And it is an absolute contraindication after a solid organ transplant. This is correct. Or it is false, rather, I would put it that way. It is not an absolute contraindication. Sometimes, even after rejection, you can use it to support the organs. If you remember, one of the questions that we did earlier did mention this fact. ECMO may support recovery in severe primary graft dysfunction. So this is what it is. And post-transplant ECMO always indicates futility. Again, this is wrong. You're using it in graft dysfunction. And of course, if need be, you can use it to support organs. So blood transfusion practices in transplant ICU patients. Uh, in transplant, so first option is restrictive transfusion strategies are commonly applied in transplant ICUs. That is first option. Blood transfusions can increase HLA sensitization risks. That is second option. Transfusion has no immunologic implications in transplant recipients. That's third. And fourth is platelet transfusion thresholds depend on bleeding risk and the procedure type. So can we have the answers now? Okay. TTFT, TFFT. Okay. So two of them were similar, one of them is different. So let's see. The answer is TTFT indeed. So restrictive transfusion strategies are commonly applied in transplant ICUs. That is correct. And blood transfusions actually can increase the HLA sensitization risks, which is why it is felt that probably, using too much of blood products may not be a good idea. C is, of course, transfusion has no immunologic implications in transplant recipients. That is correct. And platelet transfusion thresholds, of course, will depend on the risk of the bleeding and the type of procedure that you want to do for these particular patients, from lines to lumbar punctures to any other invasive procedure. Okay. Right. So this is slightly hatke question. Vaccination in transplant candidates and recipients. So first option is inactivated influenza vaccine is recommended annually post-transplant. Second question is live vaccines are preferred after transplantation. Third is vaccines are ineffective in all transplant recipients. And D is pre-transplant vaccination improves post-transplant protection. So can we have the answers now? DFFF. There's a huge consensus in this answer. So we look at it. Is the last option is correct, that is true. So inactivated influenza vaccine is recommended annually post-transplant, that's correct. And live vaccines are not preferred after transplantation. Vaccines are ineffective in all transplant recipients, this is wrong. And pre-transplant vaccination will improve post-transplant protection. This is true. Now we come to donor-derived infections. So option A is organs from bacteremic donors may be used with targeted antibiotics. Second option is donor fungal infections are at low risk for recipients. Third option is donor screening reduces transmission of infections. And D is donor-derived infections never affect graft survival. Then we have the answers, please. TF. Anyone else? Mutin has answered. Mustaba, Utpal. Again, consensus sort of thing. Only Arunima has answered differently. So let's see. So TF is correct. So first option, organs from bacteremic donors may be used with targeted antibiotics. This is correct. Donor fungal infections are low risk for recipients. This is false. The recipients can acquire bad fungal infections if the donor has been having or harboring a fungal infection. Donor screening reduces transmission of infections. This is correct. And donor-derived infections never affect gas survival. Obviously, it is wrong because the other three statements, if you view them in totality, then you will understand that this cannot obviously be correct, even if you were to not to know the correct area of that. So donor-derived infections do affect graft survival. Okay. 14th is febrile neutropenia in hematologic transplant ICU patients. So first option is empiric pseudomonal beta-lactam therapy is first line. Second option is the antibiotics should be delayed until culture results are available. Third option is the empiric antifungals are not added in persistent fever. And fourth option is granulocyte transfusions are routine standard of care. Can we have the answers, please? Faimuddin has everything is false. Who else? But Sharma is TFFF. Dhani is again TFFF. Mustafa is again all FF. Okay, let's see. So it is TFFF, and the empirical antipseudomonal beta-lactam therapy is indeed the first-line drug, and antibiotics should be delayed until culture results are available. This is false. You need not delay your antibiotics because the mortality goes up, and you may not find classical presentations of sepsis here. Empiric antifungals are not added in persistent fever. This is again false. They are added if the patient is having persistent fever. D is granulocyte transfusions are routine standard of care. Again, they are not routine standard of care. So this is what? Right. Ah, okay. I hope nobody seen that. So sorry about the good. So renal replacement therapy after transplantation. First option is CRRT is preferred in hemodynamically unstable patients. Second is the RRT modality does not affect immunosuppressant drug clearance. Third is early CRRT will prevent allograft recovery. And fourth option is acute kidney injury requiring renal replacement therapy is common after major solid organ transplantation. Right? So, can I have the answers now? EFF, Faimuddin has given that. TFFT, TFFF, TFTF. So now all variations have come in. Okay. So it is TFFT. CRRT is indeed preferred in hemodynamically unstable patients. This is an easy option because I've done AKI module, so I know that this may not be a very tough statement or tough conclusion to arrive at. RRT modality does not affect immunosuppressive drug clearance. It is false. It does affect it, and it does impact drug clearance. Early CRRT will prevent allograft recovery. No, it is wrong. It has got no bearing with that. Fourth option is AKI requiring renal replacement therapy is common after major solid organ transplantation. It's correct. It can happen, and it does happen in many of the occasions. Okay. So post liver transplant, acute kidney injury or AKI. First option is calcineurin inhibitors are an important contributors to post-transplant AKI. Second is hepatorenal syndrome can persist after liver transplantation. Third is early post-transplant AKI is associated with increased mortality and graft loss. Fourth option is AKI after liver transplant is always reversible. So can we have the answers now? Okay, TTTF, TTF, TTTF. So there's a huge consensus on this one. Fine. Let's see the answers. This is correct. Whatever you have spoken at. So calcineurin inhibitors are indeed an important contributor to post-transplant acute kidney injury. Hepatorenal syndrome can persist after liver transplantation. This is correct. Early post-transplant acute kidney injury is associated with increased mortality and losing the graft. That is also correct. And AKI after liver transplant is always irreversible. No, this is wrong. These patients may be subjected to RRT techniques and this becomes reversible after some time. Right. So invasive aspergillosis in solid organ transplant ICU patients. First option is lung transplant recipients have the highest risk of invasive aspergillosis. Second is galactomannan testing can help diagnose invasive aspergillosis. Third is voriconazole is first-line therapy for invasive aspergillosis. And fourth is aspergillosis usually presents only after the first post-transplant year. This should be an easy question to get, in my opinion. So TTTF, okay, TTF. Okay, good. I think most of you are getting it correct there. Um, so lung transplant recipients indeed have the highest risk of invasive aspergillosis. And galactomannan testing indeed can help you in terms of diagnosing invasive aspergillosis. There can be some questions based on what are the type of fluid you may be talking about, but in general, galactomannan testing is a strong pointer in favor of invasive aspergillosis. Voriconazole is first-line therapy for invasive aspergillosis. This is correct. There can be certain other options in terms of combination of anidolafungin with voriconazole for a few days. Certain people talk about isavuconazole, but still voriconazole is an old tried and tested hand in terms of invasive aspergillosis. And it usually presents only after the first post-transplant year. This is wrong. It can present even during the first year or during an early duration as well. Okay, now post-transplant lymphoproliferative disorder. So PTLD, it is commonly referred to as. It is commonly associated with Epstein-Barr virus infection, first option. Second is reduction of immunosuppression is the first step in management. Third option is PTLD can involve the transplanted organ. And fourth option is it is limited only to pediatric transplant recipients. Can we have the answers? Okay, everybody seems to be getting it right. Let's see. So PTLD or post-transplant lymphoproliferative disorder is indeed associated with Epstein-Barr virus infection. And reduction of immunosuppression is indeed the first step in management. It can involve the transplanted organ. That is also true. And it is not limited to pediatric transplant recipients. It can manifest in adults as well. So this is correct. Right. So mechanical ventilation in lung transplant recipients. So option A is lung protective ventilation strategies are recommended in lung transplant recipients. Second is high tidal volumes improve the graft oxygenation and should be used routinely. Third is bronchoscopy is commonly used to evaluate early graft dysfunction. And fourth option is primary graft dysfunction can mimic ARDS radiographically. So can we have the options, please? Can we have the answers, please? Okay, TFFT, TFTT. Anybody else? Oh, so TFTT seems to be the more common one, which is correct. So lung protective ventilation strategies are recommended in lung transplant recipients. That is correct. That is true. And high tidal volumes can still improve your graft oxygenation, should be used routinely. This obviously goes against the first statement as well logically. But other than that, be clear that this is false. Bronchoscopy, yes, it is commonly indeed used to evaluate the early graft dysfunction. And primary graft dysfunction can actually mimic ARDS radiographically. Again, part of these options we've discussed in the earlier questions. Which brings me to my last question for the day. So, sepsis in hematopoietic stem cell transplant recipients. So, HSCT patients have a first option is HSCT patients have a high risk of multi-drug resistant infections. Second option is neutropenia alters the clinical presentation of sepsis. Third is, of course, broad spectrum antibiotics should be started immediately in septic hematopoietic stem cell transplant patients. Fourth option is blood cultures are unnecessary before starting antibiotics. And we have the answers to this. This is a relatively easy question now. I think everybody's getting it right. Right. So is indeed TTTA. So they do have a high risk of multi-drug resistant infection because their immunological milieu is low. So that can happen. This is also true that neutropenia will alter the clinical presentation of sepsis. It is true that broad spectrum antibiotics should be started immediately. We've covered the anti-pseudomonal antibiotic part early, and blood cultures are unnecessary. No, this statement is false. So it is not, it is absolutely mandatory to send off your cultures, especially in HSCT recipients, before you start your antibiotics. This is it. I hope that the session was good for you. I hope that you were able to, sort of pickle your brain with these questions with regard to commonly occurring issues in transplants. The idea was just to give you a broad overview about what all things can come in transplant related questions. And this is what is the stuff that is commonly supposed to be covered in this thing, right? Okay, Arunima has asked, so could you please highlight some important topics in transplant? Arunima, if you've gone through my earlier class, I tried to cover that, and a lot of this is overlap and some more details of the questions that I asked earlier. Do you have a recording of that? Actually, more of drugs and more of immunological reactions and rejection is what you should be knowing about. Because other things are standard, when to do ECMOs, when to do your bronchoscopies. This is fairly easy hat, but just little bit of finer point should be good enough. I'm not asking you to deal with transplant with too much in detail. That is not required. But if I'm correct, when I went to the case vignettes last time for my transplant, I covered, sort of one case scenario each for each. So you can go through it to just to form a basis about what you would need to read. And you add on to it with these type of questions and you can go through this. Okay. So best of luck for this section and I'll take leave for the day. Thank you for
Thank you, sir.
listening. Yeah.
Thank you, all the aspirants. Next class we'll be having soon. Thank you, everyone.